welcome. We had this excellent opening ceremony. Now we start the scientific program with the presidential session. Thank you so much once more to the Spanish friends, mainly Luis Ocaña and all the team, for hosting us in this marvelous city. The session starts with the presidential address. So Paulina Salminen will give her address.
Okay, just to say thank you. We are going to start this session. Doctora Salminen.
You can sit down.
Okay. No, sir.
Thank you very much. So it is wonderful to see all of these people here. And this is actually the first time we decided to add a presidential session to the IFSO-EC Congress. And I think it's wonderful because then I can speak about anything because the topic is like absolutely free. So I can speak about things that I think that are of interest to me and I hope also for all of you. I actually wanted to do this in a way to showcase what IFSO does because being a part of IFSO has really been an extremely wonderful experience, and I think there's a huge group of people that are really working hard to make a difference in our patient lives, and along with that, we still end up having a lot of fun together, and you make friends all over the world. So I think this really is an IFSO family, and. Of course, you have to show your disclosures. These are mine. My disclosure is that this is the presidential address, so I got to decide what I talk about. And none of these disclosures are relevant for the topic. Maybe the fact that I do think, and I'm probably going to say this up until the end, is like I will never stop saying it, but I do think we need to step up our game within metabolic bariatric surgery, that we aim for even higher quality research than we currently do. Because within this era that we live in, I think we do have to think about the whole field of obesity treatment in a completely different setting than 10 years ago. I think everybody has to embrace that. It's not the same environment that we currently live in. So with the current era, and this is a picture trying to show that what can actually happen, because we were, just this afternoon, we had a meeting with this global obesity guidelines that involves World Obesity Federation and EASO and IFSO. And I think the idea of us trying to create a practical guideline for practicing physicians, that they would be able to get more patients within active treatment. And this is, again, it's not, a step-up approach doesn't mean that surgery would be the last option. On the contrary, I think we live in a very exciting time. So in my mind, the idea is that we actually have so many questions that we need high quality research for, is that how do we optimize the use of all treatment options that we currently have available? And it's not definitely pro-con, it is absolute synergy, but we just have to figure out how to do that in the best possible way. And in my mind, the only way to do that is through research. And I think this new era is something that, as I said, everybody has to embrace, and I'm really proud that our federation actually did this. So last year, IFSO changed its name to be International Federation for the Surgery and Other Therapies for Obesity, embracing the fact that we now have more tools in the box. And we do need the tools in the box, because when you look at, and this still puzzles me every single time, because during the past 2 decades, we have accumulated so much evidence-based data on the outcomes of metabolic bariatric surgery, and still the patients that have access to surgery and they would be eligible for surgery and they would clearly, evidence-based, they would benefit from surgery. Only 1% to 2% globally actually have access to that treatment. And I think this is like I said, it keeps on puzzling me. I don't really understand how we have been not so very good at marketing, because we do have data to back this up. Because when you turn this around, it means that we're literally, I don't know any other chronic disease that doesn't treat 98% of the patients. And I think this is something that should actually worry us. Instead of, skimming through the not so important details, in the bigger picture, we need more patients with inactive treatment. And as was already said in the opening ceremony, I think we do need to identify the issues that we currently have in marketing our treatment, and this can only be done in collaboration with the whole field of physicians and healthcare professionals that take care of severe obesity. I think this is definitely a joint effort that we do have to do together. As we do have, I still like, and this is of course again very biased because it's a invited commentary on the battery optimized trial that we wrote with Ali Aminian for JAMA Surgery, but I like our title still. It is, I think it really needs all hands on deck approach. And now we have more tools in the box. And in order to embrace this, I think, in my mind, we could actually learn a lot from the medical community in marketing this treatments with the current obesity management medications, because there literally is no magic bullet for obesity, which also is a very good title. But in order to be central players, we do need to be taken seriously. I was wondering about the marketing. I don't know whether anybody has a good answer for that, but when you look at for the past 2 decades, our complication rate, like for benchmark cases, we are very safe surgery. It has really gone down. The complication rate, the mortality rate, we are really safe surgery when you look at it objectively. We have 40 years data from the SOS trial showing that you can increase your life expectancy. I really want to think about if oncologists would actually come up with a new drug that says that you can increase your life expectancy by 3 years. They would be all over the place shouting that out. And we're still somehow not able to convey that message. So I was trying to think what we should actually do. I'm not saying that this is what we should do, that we put up billboards, but for marketing, I think we do need to think outside the box, because apparently when you look at the past 20 years, we really have not been doing a very good job. The utilization of metabolic bariatric surgery is still extremely low. Again, we leave 98% of the patients without any treatment, and we still take care of all the obesity-related comorbidities or obesity complications. So maybe we really need to think this through, and I think this is best done together with the medical community. And another thing I think we do need to market is that this is very safe surgery. So a lot of the patients and even our primary care physicians, sometimes they still perceive metabolic bariatric surgery as being very high-risk surgery, which we all know that it's not. So I think this is something that we all need to think about and maybe hopefully figure out a solution, because even with the data that we have, we all know that implementing research results within clinical practice, it takes about a median of 17 years for any result to be implemented in clinical practice and guidelines. So we do have our work cut out for us to take this information forward. And in that sense, as I said, I could pick the topic. So I think the crucial thing that we do have to focus on is high-quality research. Metabolic bariatric surgery still sometimes is perceived as that we create this procedure, but we literally have no follow-up for that specific procedure. I think we need to embrace the standardized procedures, and we cannot be perceived as cowboys that create procedures without no follow-up. So we do need to have data, because otherwise it is just our opinion. And in this context, I want to highlight that I'm absolutely not against innovation. I'm all for innovation, but in my mind, when you treat patients, the innovation has to be, if you do an innovative procedure that does not have data to back that up, you have to do it within an IRB accepted study, and you have to have long-term follow-up. And I wanted to conclude by kind of highlighting the research, and of course, as I'm a huge fan of randomized clinical trials, I just want to encourage everybody, when you think about choosing what kind of research you do, if you want to change practice guidelines, if it's possible to randomize, then it's a very easy flow chart. Just do a randomized clinical trial. I do think it's much better to focus your energy, time, and funding on high-quality research, one study instead of multiple retrospective studies or systematic reviews. Focus your time, energy, and funding on high-quality research that potentially has an impact on clinical practice guidelines. I do want to highlight that I think I fully understand, having done randomized clinical trials, it is a huge amount of work. And I do get that it's not always possible, but there are a lot of people that work in high-volume centers, a lot of countries that have very good registries. So I would really stress the idea that we also, in addition to RCTs, we do need prospective, big data, real-world data, because, of course, RCTs are always in a selected patient population in a selected center. So I think this is good, and I wanted to show you, I think a good example of this is actually, I think Francesco is somewhere in the audience, but this is the Genoa series with a 30-year follow-up of the biliopancreatic diversion. I think it's definitely worth for them to show their results in a large prospective cohort. I wanted to conclude with showing what IFSO's done. And we will have 2 separate lectures on IFSO position statements. But I think I just picked out a few. This is the obesity management medications and a Lancet that Ricardo's gonna, I'm not gonna steal Gerhard's and Ricardo's thunder, so they get to present that. Wendy Brown spearheaded the gastroscopy update on position guidelines. We just did before that, the definition one, because language really matters. In a disease, in a chronic heterogeneous disease such as obesity, it is really important that we refrain from using any stigmatizing language. There's a huge stigma with obesity, and we need to avoid it. We also did one in the Mumbai Congress for sleeve gastrectomy, and one in the Santiago Congress for the endoscopic sleeve gastrectomy. This is the OMM one in Vienna, which I'm going to let Gerhard take care of. This is the one in Lancet Diabetes Endocrinology, which I like, and Ricardo is going to take care of. But this is my kind of bridge to what I wanted to show you about the terminology. Due to the sake of time, I cannot go over that in detail, but this was the idea of having a position statement on patients that actually have a very good response for OMMs, but they, for some reason, want to stop taking the medication. So the idea is that we have to use the baseline weight prior to OMM initiation as the criteria for surgical indication. And for this, for the definition one, there was actually a very long discussion about the baseline weight. How do you define it? And again, apples and oranges, and for somebody that's not familiar with the English idiom, that means that, you know, things are not comparable, because if you take your baseline weight on the day of the operation versus you take your baseline weight on the day that you start anything, any supportive measurements for the weight reduction before the surgery, it actually is very different when you look at the weight loss outcomes. So the consensus was 95%, not 100, but 95%, was that the baseline weight needs to be determined for the weight determined before starting any preoperative weight reduction. And this is, I think, very important because when you compare different studies, you actually have to know what you are comparing. So the definitions really matter. And this is, again, I think a good example of language because in this consensus paper, you still see AOM, so anti-obesity medications, but I will let Gerhard tell that story because it really now is obesity management medications. For the terminology, I just wanted to take, like, you know, I wanted to have 4 top of my head, like no words. So these are the ones. Please never use these. Do not say failure. Do not say obese patient. Do not say morbid obesity. Do not say super obesity. You have to, and that's from the consensus paper. So if you don't have a weight loss that you would be satisfied with, either with the weight loss or the comorbidities, it is suboptimal initial clinical response. If the weight goes back up again, it's recurrent weight gain. And please remember always to use patient-first language, so it's patient with obesity. It is severe obesity or obesity classes. Do not say super obesity anymore, because language does shape stigma and care quality. I will just, at the end, because we had a few extra minutes, wanted to highlight Wendy's hard work on the gastroscopy paper, because I think this is globally very different. And we updated this by doing a lot of reading of the literature. And there was in 35%, there was an abdominal endoscopy requiring medical management. So this is the preoperative gastroscopy. In 23%, there was a finding that led to delay or change in this metabolic bariatric surgery. So the conclusion for the preoperative endoscopy was that it should be strongly considered. It was almost that we said that it should be done, but strongly considered equals actually that. I want to conclude by saying thank you to Luis and the whole local team of Malaga. I have here, we have this presidential session, so I have here with me our past president, Nicola Di Lorenzo, and our president-elect, Catalin Copescu. And I really want to thank our IFSO European Chapter Executive Committee, Manuela, Stephanie, every single person in the picture and the ones that already left. We had a very long meeting last night. And I do encourage people to join this extremely fun group. So we will have an open application for all committee positions starting a few weeks after the Congress. So please be alert and send in your application. And I do hope to see everybody in Toronto and then with our joint meeting in Munich together with ASO in May 2027. Thank you very much.
Thank you very much, Paulina. After this excellent talk, thank you very much, Mr. President. It is my pleasure, as I am honored to co-chair this presidential session, to introduce Professor Gerhard Prager, former president of the European chapter, former president of IFSO, and he is going to talk about the IFSO position statement, obesity management medication in the context of metabolic and bariatric surgery. Thank you very much.
Dear friends and colleagues, thanks for the nice introduction, Catalin. Obesity management medication is one or maybe the hottest topic in our field currently. IFSO encourages all speakers to show this case mix slide, that you know that I'm talking about something, if I talk about OEGB, that I really do it or not. These are my disclosures, and you see in 2026, surgeons also have grants and are in advisory boards from pharma companies. In 2024, IFSO European chapter took place in Vienna, and we took the chance to run a very extended Delphi consensus conference during this Congress. And the reason for that was that we had not enough evidence on the use of obesity management medications in the context of metabolic bariatric surgery. And we covered preoperative use of obesity management medication as an adjunct therapy and also future aspects. Why is this so important? You see here current numbers published very recently. You see a dramatic increase in the use of obesity management medications, and in some areas of the world, also a decrease overall in metabolic bariatric surgery. But this decrease might be only temporarily. We also know that in some areas the numbers already take up again. And we were very glad to host an incredible faculty with really top physicians, thought leaders, and also surgeons. And I'm very glad Professor Volker Newmuck, the president of EASO, is currently here with us, and we have a very strong association with other big societies all over the world. So this was the core group: Ricardo, Luca, Randy Levinson, a Delphi expert from the US, and me. And prior to that Delphi conference, we ran a systematic review, sent all the evidence to all the experts to have the same level of expertise, and each one had to define 3 to 4 Delphi statements. And finally, after running 3 rounds before the meeting, we met in Vienna, and you see the consensus and level of agreement on the right lower corner side. In Vienna, we ran through different talks, and I won't run you now through all the statements, just through the top statements. We published that in British Journal of Surgery, and of course, you can read it your own. First big block was the use of obesity management medications before surgery. And what is the rationale behind it? Number 1, you could reduce the perioperative risk. And number 2, the proportion of those achieving weight loss goals, and also improvement in obesity complications, former comorbidities. New language, Paulina. What is the evidence behind it? I just pick a few papers for that. You see more than 500,000 of patients, and the take-home message is when you lose weight before metabolic bariatric surgery, you can decrease morbidity and even mortality. So statement number 1, there is insufficient high-level evidence to recommend the routine use of obesity management medication for weight loss before metabolic bariatric surgery. And you see consensus 100%. There are also studies now after our consensus meeting that showed exactly that. I took just one from JAMA Surgery. In this one, you see no reduction in complication rate, but keep in mind the mean pre-op BMI is here 42.6. So, second statement, the decision to use OMMs before metabolic bariatric surgery should be personalized to determine the most appropriate strategy. And such special circumstances can, of course, be very high BMI, a very advanced degree of disease in terms of liver disease, cardiovascular disease, or even end-stage kidney disease. And we learned a lot from surgery. Things we can also use now for obesity management medications. You might be aware of the terms Ozempic face and Ozempic butt. This reflects a loss in lean body weight. And we knew that from metabolic bariatric surgery. So next statement, healthy nutrition, including adequate protein consumption and resistance exercise, is recommended for those treated with OMMs prior to metabolic bariatric surgery. And I change now to the next big block, the use of OMMs after metabolic bariatric surgery, either to optimize the outcome or in the use of recurrent weight gain, former weight regain. And the first statement is, when should we start with the OMM after metabolic bariatric surgery? And there was a 100% consensus to start after the achievement of a weight plateau. Why? Otherwise, you cannot differentiate between the effect of the OMM and the effect of metabolic bariatric surgery. And this, of course, is the idea of adopting a multimodal approach to care. You see here the spaghetti plots of the SM-BOSS trial. And what we learn is even with a very strong intervention like metabolic bariatric surgery, where we achieve a total body weight loss of 30%, there are individuals that respond not in a way we would like. So there is, on an individual basis, a need for other therapies in sense of a multimodal approach. Of course, we know nowadays when we use OMMs postoperatively, it is very likely that they are needed for chronic use. There are several studies, the SURMOUNT-4, the STEP 1 extension trial, this one summarizing data from 13 RCTs. When you stop the OMMs, you must think that there is a regain of weight. A chronic disease needs a chronic treatment. And of course, you can expand your thoughts. Professor Salminen just said before that only a minority of patients eligible for metabolic bariatric surgery is willing to undergo metabolic bariatric surgery. We are effective, but we are maybe not sexy. Also, we reduce invasiveness. And you can think out of the box. If you reduce your invasiveness further, like with endoscopic sleeve gastroplasty, and you combine this with obesity management medication, you reach higher efficacy. Saying that, you see also that the consensus for this statement was only 74%. So not all experts were 100% convinced by our wording, and the evidence, honestly, is also not so strong for this statement. This is my favorite statement of the entire consensus conference. For patients with recurrent weight gain, treatment with available OMMs should be considered prior to revisional surgery. Why? Because we have no good long-term data on the efficacy of revisional metabolic bariatric surgery, and you have to keep in mind that revisional surgery means higher morbidity. On the other hand, we have an excellent safety profile for OMMs. This statement must be seen in the context of availability, of costs, and willingness of the patients. You can expect for different OMMs, of course, different efficacy, currently with tirzepatide on the top. GLP-1 receptor analoga are associated with meaningful weight loss in patients with suboptimal clinical response and recurrent weight gain, the new terminology as Professor Salminen mentioned before. Future perspective, let me just finalize with two more statements. People living with obesity need access to all evidence-based treatments, including surgery and medications, as part of standard healthcare services. And this is, of course, something our policy makers have to do. This is written into their to-do list. Maybe some of you know this gentleman. This is one of the most famous physicians of the 20th century. He got the Nobel Prize in 1945. This is Sir Alexander Fleming, who detected penicillin, and he got the Nobel Prize in 1945. And when penicillin came to the market, it was one of the most expensive drugs ever. It was so expensive that the urine of patients was used to extract penicillin again. But you see what happened after a few years when industrial production of penicillin came to the market. The price dropped dramatically. And nowadays, maybe OMMs from an economic point of view might not be cost effective. But this is only a question of time, and we have already announcement that the prices, and we see it already, will drop dramatically. And of course, a ton of new generation of obesity management medications are just around the corner. So it's only a question of time until we will see obesity management medication at a favorable price entering the market. I stop here. I want to thank once more our fantastic entire group that gathered in Vienna, and also want to invite you to Toronto this year, and of course to the joint congress with EASO next year in Munich. Thank you very much.
Thank you very much. Thank you very much, Gerhard. Can we have the microphone on? Thank you. We decided that we will have the panel discussion at the end. So we will move forward with our next position statement, and it's my pleasure to welcome Professor Cohen directly from up in the air. Literally arrived probably an hour ago. So we're very delighted to have you. So of course he does not need the introduction. He's the immediate past president of IFSO, and actually for the World Obesity Federation, the Clinical Care Committee chair. So we're very happy to have him also in that role. Ricardo, please.
Thank you, Paulina. Hi, Nicola. Hi, Kathleen. Thank you, Luis, to let me present here. I'll present today on behalf of the co-authors, Gerhard, Paulina, Ildiko Lingvey, who's a prominent endocrinologist, and Carol Leroux, on our first position statement that was published outside the surgical literature. We could get that position statement published at the Lancet on the use of metabolic and bariatric surgery after a successful use of obesity management medications. Those are my disclosures. Some of them are related to this presentation. Well, this audience, it's a no-brainer that we have two pillars today for the treatment of obesity, and they serve as complementary roles. First, OMMs, they have meaningful and impactful weight loss and health improvements. However, they require, at least so far with the data we have, lifelong use, and OMMs work with surgery. And we have metabolic and bariatric surgery that provides sustained weight loss and metabolic improvement, offers a single durable intervention, and all interventions, all operations work with OMMs. However, we understand that this is very fresh, was published 2 weeks ago. It's a meta-analysis on what happens when people stop using the medication. So on top of the recurrent weight gain, we see the recurrence of the complications of obesity, the signs and symptoms of obesity. So we have some eligibility challenges. Number one, if a patient loses significant weight on OMMs and remits his or her complications, do they still qualify for surgery? Well, they started OMM, they had good outcomes, however, they lack of access for any reason, they have long-term side effects, the cost of continuing medications may be a burden for them, or simply they don't want to take medicines anymore. It's a situation that we're seeing more and more frequently in our center. And then they don't meet the old-fashioned BMI-based criteria. So what should we do with those patients? Deny the access to metabolic and bariatric surgery? We learn with drugs that, yes, their problems will recur. And second, we have the second eligibility challenge, that's the patient clinical risk profile still warrants an intervention. So first, what would be those risks? Persistent signs and symptoms of obesity or the recurrence of obesity-associated diseases like diabetes, hypertension, for example, a poor overall quality of life due to obesity itself, and the high likelihood of recurrent weight gain. So this is an illustration that was adapted from our position statement. So we can see here that patients start using medication. If they don't use, of course, no treatment, weight goes up, the weight goes up. If they start obesity management medications, their weight goes down. And at a certain point, OMM, for the reasons that I presented earlier, they stop the medication. If you let them without the medication, look at this red line after stopping, the weight climbs up. Exactly like the extension of the step 1 trial, for example. It's exactly the same thing. So why not offer to those people metabolic and bariatric surgery? It's a continuum of care. It's not one against the other. We have some ethical considerations to deal with. First, we have the patient's autonomy. Patient may prefer an intervention over lifelong medications, right or wrong. We're not judging if it's right or wrong, but their choice should be respected. This leads to shared decision-making. So decisions based on patients' goals, preferences, long-term risk, and the data that we have needs to be respected. We need to avoid unnecessary harm, requiring recurrent weight gain to qualify for surgery. It's something dumb. We pose risk to people that had the risk that went down with the obesity management medication. So we would avoid risks. And with that, we have equitable access to all treatments, either metabolic bariatric surgery, OMMs, and both together. MBS eligibility should reflect diseases principles, not only metrics, not only weight. First, focus on the biological nature of obesity. It's not just the current weight or the past weight. Second, it's clear for us today that medications and surgery are complementary. So we don't see today medication or surgery, or who should deserve first medications and escalate to surgery, or vice versa. This is the process. It's a continuum of care and not competition. I like to say, and I used to say this for several years, that we're not sexy anymore. Surgery lost its sex appeal. However, we're cheap. Metabolic and bariatric surgery is economically dominant for 4 to 6 years. It depends on the literature. Obesity medications is a lifelong cost, and it's a high cost per quality. So it's around, at today's prices, around $400,000. Of course, as Gerhard mentioned, price will drop. Of course, price will drop. I don't know if you know, statins, when they were released, they were something unaffordable. And today is a medication that is current. So medications are here to stay. Prices will go down. However, it's an ongoing cost. So we still have unanswered questions. First, is there a minimum weight threshold before metabolic bariatric surgery to be performed? We don't know the answer. Probably not. We're not looking to the weight itself, but the consequences of excess adiposity. Should surgery based on the initial evaluation or adjust OMMs to weight loss? So probably this needs to be done in research. We have some strategic priorities. We need to report the outcomes from the highest pre-intervention weight. We need to understand obesity phenotypes for uniform criteria. And we need to conduct prospective trials and health economy studies. Surgery may pay itself for 4 to 6 years, but it's an ahead cost that the insurance systems may have to support this. So surgery plus OMMs, we need to understand the economic burden of this. However, I'm pretty sure that the outcomes will be so favorable that the cost per quality will decrease. The ICER, it's the incremental cost, will decrease and a lot. And finally, the conclusion is we integrate OMMs and metabolic surgery. The weight itself, the weight loss itself achieved by OMM should never be used as the single reason to deny access to metabolic bariatric surgery. And eligibility should be driven by chronic disease burden, not weight alone, pre-OMMs, and we need to provide effective long-term care to our patients. Thank you very much.
Thank you very much, Ricardo. And we will then have a very interesting, it's not going to be a fight. It's going to be a discussion, because we have two societies that actually have aimed to define obesity in a very different way than we have previously been used to. But it's there are some discrepancies between the definitions, and it's going to be interesting to listen to the IFSO version and kind of the Lancet Commission version, and then also the ASO version. So we're delighted that we have, yes, he's ASO people, but We're not really polite because we put the Francesco and Ricardo to start. It would have been kind of polite to let our guests be the first, but we will stick to the program. And Ricardo and Francesco?
Ready?
Yes?
Are you ready? Okay.
You let your Italian friend go first, okay?
I think most people know this Italian friend, and it's my privilege to introduce Francesco Rubino, who has been so persistent, resilient, and working on this topic for many, many years and giving the great results that he will illustrate to us now. Thank you, Francesco, for being here.
Thank you very much for inviting me. Thank you, Paulina. Thank you, everybody. And also thanks, Ricardo, for allowing me to present, and then we'll discuss together. These are my disclosures. Yes, we're going to discuss different definitions of obesity, but I'd like to point out that these are not quite the same things. I'm glad that we discussed this in the same session, but they don't belong to the same type of definitions. There are different things, and I hope my presentation will explain clearly why this is the case. For those who don't know, the Lancet Commission, this is a work of 4 years of 56 international experts, reported in January 2015, and in a little bit of more than a year has been cited 1,600 times as of today. This attests for the interest on the topic. Normally, the lifetime citation of a paper is about 70 in a big journal, so you can imagine that this is quite a remarkable outcome. It's been also quite favorably received in the media and also in the medical community. We had 76 endorsements. But in spite of the endorsement and the enthusiasm, it's not like there isn't discussion and debate, which is always welcome. And some were few, maybe, but very vocal objections, questions of all sorts. I will address those one by one. So, because of this debate, it's important that I explain what the Commission is, but more important, perhaps, is what the Commission is not, okay? And the Commission is not a clinical guideline. The Commission is not a management framework. It's not about management. It informs management, but it's not treatment guidance. It's not a narrative of obesity, a new narrative. It's something different. It's not the EASO framework. It's not the Canadian guidelines. It's not the Edmonton scoring system. It's a completely different, conceptually and practically, completely different subject. So what is it? It's enough to look at the title. I know many people don't read the papers, maybe not even the abstracts, but the title. The title says diagnostic definition and diagnostic criteria. So it's a clinical diagnosis. That's what it is. Keep that in mind. So a little bit of a background to give you a sense of why this was put together. It comes from the realization I was thinking around 2019 about this issue of obesity as a disease and why it was so controversial. And to me, it was quite odd that something that should be a matter of evidence and science was a matter actually of opinions. That suggests there is something wrong, maybe a cultural gap or an evidence gap that doesn't allow this question to be settled. The other question is this: if you start thinking about from a clinician perspective, from a clinician standpoint, what does it mean that obesity is a disease? Should I tell everybody who I see with obesity, everybody in this room who has a BMI around 30, you have a disease here and now? When you start thinking that way, it becomes a little bit more problematic than just saying, I was one of those who say obesity is a disease all the time without any specification. And then when you start a little bit thinking about, as a clinician, you get that responsibility of being clinical, which means precise. The other consideration was obesity is not new. The epidemic of obesity is new, but obesity has been around for thousands of years. So why did doctors in the past not define obesity as a disease in the same way as defined diabetes as a disease, Parkinson's disease, and everything else? Were they not noticing that obesity has a health impact? No, they did. Hippocrates did. Hippocrates said obesity can be a disease, so he noticed. But he also said it could be a harbinger for other diseases. But he also said obesity can actually make people fare better when they have other diseases. This is what we call today the obesity paradox. So across history, doctors have noticed that obesity is a disease, but could be also not a disease in some people. In other words, the individual manifestation of obesity has been heterogeneous throughout history. And this hasn't bothered doctors. They were able to say it could be all of those things. Because of that heterogeneity, they haven't come up with a uniform definition. Because there is no uniformity, you can't give a uniform definition. So it all changed in the last century when the life insurance industry, not medical profession, decided to give a uniform definition of obesity as a risk factor, not as a disease. And that is that's where our problem started. This uniformity that doesn't exist has been started in the 20th century, but wasn't there before. The other problem is we don't have, because of that very reason, we don't have a disease definition for obesity. But in medicine, we normally have a definition before we have a diagnosis. And the definition is what is the disease? Answers the question, what is the disease? What does it look like? What are the signs and symptoms? So by design, a definition is singular. Okay? It's about a single disease. The diagnosis is nothing else than the second step. It actually is based on the definition. You cannot have an accurate diagnosis if you don't have an accurate definition. And the diagnosis detects that very disease, not another one, that disease, and distinguishes that disease from others. The more disease overlap, the more people go great lengths with differential diagnosis to differentiate those. So it's exactly the contrary of what we do in obesity. When we say there's 200 associated diseases, that's interesting. But when you come to disease diagnosis, it is about where is the singularity? What is the single disease? When we say it's a standalone disease, it has to stand alone. Okay? And then, of course, we have staging, stratification, we have management frameworks where we understand that people don't have just one disease, they have multiple. And sometimes these multiple diseases don't happen just by chance. They have overlapping pathophysiology, they compound one another. So when you treat somebody, you might want to treat more intensively because there are multiple comorbidities that could benefit from the treatment of the index disease. But that's a different concept than a disease diagnosis. So when we put diabetes and mental health and everything in the management framework, that's correct. But you don't put those things, you don't put other diseases in the disease definition and diagnosis. Just because one tolerates plurality and actually encourages it. The other one is about the single disease entity. So the Lancet Commission was about defining the disease and the criteria for its diagnosis. It was not a management framework. So it's a much more narrow aim than a broader framework, if you wish. But still very important, so much important that Dr. Richard Horton, the editor-in-chief of the Lancet, said this is a before and after moment for the history of obesity, because finally we have a definition of obesity from a clinical, individual level perspective compared to what has been done so far. So when we would define clinical obesity, to some extent, we had to reverse engineer our idea of obesity, because obesity starts from population level definition. But on the other hand, we did not have to reinvent the wheel, because diseases in medicine are defined based on the ability of a pathological process to affect organs, and in doing so, determining signs and symptoms. There is no disease if there is no organ dysfunction that has a clinical impact and clinical manifestation. It's the entirety of the thing. It's the pathology and the clinical manifestation which express the pathology that makes the disease. So all we needed to do, but was not easy, was to understand where is it that obesity itself, without the help of anything else, independently of other comorbidities that may occur and compound obesity. But how does obesity affect the hearts, the lungs, etc., in peculiar ways that don't require other diseases for those things to happen? And those are the signs and symptoms, if you wish, of clinical obesity. Obesity-related diseases do exist and overlap and occur with obesity, but they have their own causes. They have their own pathophysiology, even though some of this pathophysiology overlaps with obesity, but they have their own components that are distinct. They affect organs in ways that are different than obesity. Diabetes affects they affect other organs. Diabetes affects the eye, obesity doesn't. And you want to know which disease somebody has because the way you monitor, the way you treat, etc., depends also on the evolution and the prognosis. So we define clinical obesity as a disease, clinical disease, ongoing disease determined by the effect of obesity on organs. But then we realize that there are some people who they have obesity, but they don't have organ dysfunction. And they can go on for quite some time in that status. This is something that we all know, that we see in our clinics. We can also see in this room. There might be some of us who have obesity, but they're doing well. They have preclinical obesity. We defined the criteria for clinical obesity based on those organ dysfunction that are independently generated by obesity, and we have some for children and some for adults. And this distinction of clinical and preclinical obesity doesn't draw a line because this is not a management framework. This is a snapshot. Diagnosis is like a snapshot. It defines people who have one type of health impact and people who have another. One is a risk, one is a disease. And so what the Lancet Commission says, it doesn't say treat clinical obesity, don't treat preclinical, as somebody has said, but it says treat disease as disease, treat risk as risk. That's the concept of the Lancet Commission. What are the challenges to implement? I think the most important is all of us in obesity, being used to management frameworks, having replaced clinical diagnosis with management frameworks for so long that we can't see a disease diagnosis when one appears in front of us. And because we read everything through the lens of those management frameworks, then we don't understand. We confuse what the Commission's report says. One question is, why is type 2 diabetes not a diagnostic criteria? Now, if you understood the difference between management framework and diagnosis, this question obviously wouldn't exist. But make no mistakes. We, within the Commission, we're not aliens. We had exactly the same conceptual problem, and it took forever for us to overcome this particular step and understand that, of course, in a management framework, you put diabetes, you might put mental health issues, you might put other problems that might benefit from the treatment of obesity. But that's different than a clinical diagnosis, which is singular, as I said before. And it has to be singular, and you have to do every effort to diagnose it independently, because there are circumstances where there is a benefit from doing so, especially when you need to cover obesity, but there is no one of those comorbidity for the checklist of insurance. If obesity is a disease on its own, here it is. It doesn't need something else to be covered, to be treated. Preclinical obesity, some people say that the Commission advocated for watchful weight, and there is no place in the whole document where it's written watchful weight. This is misinformation generated, I don't know where from. But what we say, disease treatment is different than risk management. Clinical obesity, preclinical obesity exists. Calculations are still ongoing, but it's anywhere between 20 and 80%. So it's a very big range depending on how you do these population studies. And medicine is used to deal with preclinical conditions. We treat polyps and cancer. We just treated them in different ways. We don't blur the picture between them. Why should we do so for obesity? Insurance, a lot of people are concerned that insurance will not cover preclinical obesity, but insurance covers everything that is pre-disease. Why shouldn't it cover preclinical obesity? If we describe what a risk state warrants properly, and we differentiate from what a disease management means, payers will understand that the cost effectiveness of those approaches are increased because you treat appropriately and proportionally. And so there is more coverage, not less coverage, by defining preclinical obesity, and anyway, by defining reality. Finally, why didn't the Commission define all obesity as a disease? The reason is because diseases are normally defined bottom-up. You define the disease at the individual level by its clinical manifestations, and then you study the pathophysiology, the population studies, to characterize more where it comes from, what triggers it, et cetera, et cetera. In obesity, we've done the opposite. We had population-level definitions, and we brought it down to the individual level. But in doing so, we saw that heterogeneity that we have seen and historically come into the individual diagnosis, which makes it very, very difficult to deal with it clinically. In fact, just to conclude, you have a problem when you look at obesity from a population level. Because it's true that if you take the population with obesity, that population looks very sick. They can have 2, 3, 4, 5 times the relative risk of something, mortality included, compared to the normal population. But what does that mean when you translate it to the individual level? It's very few actually have the problem. It's enough that you have 2 people with a problem to have twice the relative risk of that problem in the people with obesity. But what about the other 98 people? You need, as a doctor, to consider that option, and we can discuss more the EASO framework here, but here is an example of how the population-level approach distorts the use of evidence. When we say that we should treat everybody with obesity because we know obesity is associated with so many things, look at what happened. The SELECT trial, taking the riskier part of the population with obesity, looked at the placebo group. The placebo group has only 8% incidence of MACE. It means 92% of that population did not have an event. Now, if you were to treat somebody for the purpose of targeting those who have an event, you have no way to tell. How you pick those 8 in a population of 100? If you treat them and consider also that some of them will not respond to treatment, you're basically looking at potentially 94, 95% of people who either don't have the problem or will not benefit from treatment because it's natural treatment is not 100% as effective. So NNT 67, which is what they calculated, means you need to go to a casino, put your money on a single number of a single color twice, and hope you're lucky enough that it comes right both times. It's quite a gamble. So we need something more, and this is true not just for the short term of the SELECT trial, it's true in the long term as well. People with obesity, most of them would not develop the problem. That doesn't mean that obesity is not a problem. It is a problem, but it's different when you look at it from an individual perspective. And so we are clinicians, to conclude, and clinicians, unlike epidemiologists and public health specialists, we don't look at the whole group. We need to look at the individual in front of us. So when you look at the individual in front of you, we don't actually know who is going to have that problem, who has it already. If you only equate obesity to disease, you would basically not know. You would overtreat many or undertreat others. There is no way to do it. And payers don't like that uncertainty. Okay? So to conclude, the Lancet Commission, what it is not a management framework. It's a diagnosis. What does diagnosis do in the context of obesity? Obesity is heterogeneous. You take the population, there are people who are very sick, people who have a risk of future disease, and people who are doing relatively well. Okay, you want to know who is who. So diagnosis is like a prism. It refracts the light in its components. So diagnosis actually tells you that there is an homogeneous group of people who consistently have disease here and now. The treatment for those people has an intensity, acuity, urgency, etc., that is certainly different than the people who have a preclinical obesity. But preclinical obesity can be treated also with pharmacotherapy or with surgery when this is proportional to the individual level of risk. The Commission did not say, do not treat preclinical obesity, as some organizations have said. The Commission said, treat proportionally. And I think this is important because it makes a difference for payers and clinicians. I think, of course, to conclude, in the future, we will need to refine this framework by identifying a risk scoring system that scores preclinical obesity and a staging system that scores disease staging. So the ASO framework, the Edmonton framework can become better because now they have a diagnosis as opposed to working on a blurry picture of obesity overall. To conclude, this is a different thing, and we hope it's going to be a big change, but big changes don't happen easily. There's a status quo that, of course, resists in many ways for many reasons, good ones as well. The difficulties in implementing the Lancet Commission, paraphrasing this quote, is not so much in the fact that it's a new idea, it's the challenge it will be in escaping from old ones. Thank you.
Thank you very much, Francesco. That's a good sign they're still hugging. So I'm very honored to present our prominent endocrinologist, and apparently Barbara McGowan is going to take the stage on the ASO framework. She's a professor of endocrinology from London, UK, and the co-chair of the ASO Obesity Management Task Force. And then at the end, we will have a panel with all four to discuss how to take this forward to benefit our patients. Barbara, please.
Thank you very much, Paulina. It's a real pleasure to be here today and to be really given the opportunity to present the framework and to have an opportunity to have a discussion. My disclosures, of course, are that I work with Francesco, so we're in the same institution, and we're actually very good friends. So bear that in mind. But this is not a debate. Like I said, this is a chance for us to really show our framework. And what I'm going to do over the next 5 to 10 minutes, and Volkan is going to finish off to actually show you the framework, is give you some of the thinking behind, why it was put together, the thought processes as to why we are where we are. And first and foremost is the concept that obesity is a chronic disease. It is an inflammatory disease, and we know that functional adipose tissues with chronic overfeeding, intestinal dysbiosis, and genetic susceptibilities lead to dysfunctional adipose tissue, which in turn leads to adipokine secretion, reduction in adiponectin, increase in leptin, secretion of inflammatory cytokines, interleukin-6, TNF-alpha, and so on and so forth. So we know the processes, and this, of course, leads to insulin resistance, hyperinsulinemia, endothelial dysfunction, and lipotoxicity, and a number of obesity-related diseases. And of course, I don't have the time today to go through all the different molecular consequences of adipose inflammation, but the point is this is an ongoing process. This is not a binary process. And so we have dysfunctional adipose tissue secreting these inflammatory markers. We have also the immune system playing a really important part. We have pro-inflammatory M1 phenotypes, macrophages, T helper cells, again, the sort of pro-inflammatory types, which basically lead to an inflammatory environment, lots of interleukins. This triggers intracellular signaling, which leads to insulin resistance and the metabolic diseases that we know are associated with obesity. So that's the very first thing, so a chronic inflammatory immunometabolic disease. And of course, we all know that BMI does not capture the full risk of health risk. I don't have to explain this to anyone in this room. And of course, BMI does not account for fat distribution. It doesn't account for lean mass. It doesn't account for cardiometabolic health or mental well-being. So we recognize that we have to go beyond that, and certainly, new definitions have clearly gone beyond. So we have used, of course, just to make the point, like I said, the traditional BMI-centric model fails to capture true health risk. And this is just to show you data from the IMPACT-O study. This looked at a number of databases in many different countries, and essentially looking at people with overweight in the red and those with sort of the 3 different classes of obesity. And what's really prevalent is the fact that those with overweight, for example, from the UK database, 2/3 of those with overweight have at least one obesity-related complication. So, the complications really start very early, and the BMI definition, our overweight definition as we have now, this BMI of 25 to less than 30, is not capturing that. So what we did is come up with the IESO framework, of which there are many components. And Francesco did mention it's not just about definition, absolutely right. But I have to say that the focus of the first line of this framework was very much focused on the diagnosis, which includes an anthropometric component where the waist to height ratio really has played an important role. And I'm going to tell you why we really looked at sort of introducing the waist to height ratio as an additional component of the framework, of the definition, as well as having a clinical component with the medical, functional, and mental health. We did, of course, also have staging of obesity, the actual management side of obesity, and indeed we have published the algorithm specific to obesity medication once the decision to start medication has taken place, and that's really to guide really clinical evidenced medicine. But the focus was very much on diagnosis. Now, if we take the IESO obesity definition in action, like I said, which does include BMI, but also waist to height circumference, these are individuals from the NHANES database in the US. We have the normal weight individuals in the green, overweight in the blue, and the obesity in the orange. But if we include this new definition of obesity, which is really looking at BMI of 25 and above with the waist to height ratio of 0.5 plus one medical condition, then we're capturing more patients. And indeed, we have nearly 20% of people previously defined with overweight, now having obesity under our definition. And why is this important? Well, it's important because this IESO obesity definition is, correlated with increased mortality. And here we can see this that the IESO obesity in the light blue has an increased risk of mortality, of course, in addition to, our traditional definitions of obesity. So it's important to capture this population because we need to treat them earlier on in the pathway. So why waist to height ratio? Why did we choose that? Because there's evidence to suggest that it is a superior predictor of visceral fat and cardiovascular risk. And here, just to show you that, if predictive models, you can see here that the waist to height ratio is the best anthropometric measure for estimating visceral adipose tissue. So we've got associations of 0.71 waist to height ratio versus BMI is only 0.6, for example, when it comes to predicting visceral adipose tissue. And again, here on the right, if we look at the 10-year atherosclerotic cardiovascular risk, the waist to height ratio performs better at 1.58 versus a BMI of 1.15. So it is a better predictor. And indeed, actually, Luca Bozzetto took this a step further and started to look in a weight to height ratio of less than 0.53 in a large population of patients to look at this as an indicator of future disease risk. And this was better than the BMI of less than 27. So if we look at these ROC curves, which basically assess how well a measure can distinguish between high risk and low risk, the higher area under the curve signifies a better test. So we can see for type 2 diabetes, for example, which is in the light blue, the waist to height ratio scores at 0.98 versus BMI, which scores lower at 0.92. So, waist to height ratio is better for type 2 diabetes, as well as hypertension, and as well as atherosclerotic cardiovascular disease. You can see, for example, for hip and knee osteoarthritis, BMI actually scores better than waist to height ratio. But the point here is that for key metabolic and cardiovascular disease, the waist to height ratio is a significantly more powerful measure for assessing when a patient has reached this sort of low risk health state. And what we can do is actually also use these targets in clinical practice to use what we call treat to target thresholds, like other diseases, like in type 2 diabetes, we're using HbA1c threshold. For the remission, I guess, of obesity, we can use both a BMI of less than 27, for example, as well as the waist to height ratio of less than 0.53. This is the result of the SURMOUNT-5 trial, semaglutide versus tirzepatide, for example, again, showing that actually those participants achieving a treat-to-target threshold had greater than average weight reduction, around 32%. And again, we can use it in clinical practice. For example, again, these are patients, BMI of over 35 on the right and less than 35 on the left. In tirzepatide versus semaglutide, again, we can look to see how many have actually reached sort of treatment to target thresholds, which I think can be very useful when we're trying to define remission of a disease. So I will leave it there as the background. I will hand hand over to Volkan to take us through the actual framework. Thank you very much.
So welcome, Volkan.
Thank you very much, Paulina. I'm very excited to be presenting the framework from the European Association for the Study of Obesity, and just have a few slides to mention. Well, I wanted to start with this slide. This is not showing you the framework for diagnosis or definition, but this is a slide on the European Guidelines for Obesity Management in Adults that was published in 2015 for showing the way to devise management strategies for people living with obesity. And at that time, in the Obesity Management Task Force of EASO, we had a metabolic bariatric surgeon, which was Martin Fried. And we also had the collaboration with IFSO European chapter by organizing medical surgical meetings at that time. This was way back. And I had the privilege of working with Nicola Scopinaro, Rudolf Weiner, Yuri Yashkov, Antonio Torres, and others. So what we have here is that at that time, we were getting away from BMI, even for the diagnosis and mainly for management plans. So we would go for waist circumference and the presence of complications. Beneath the table, you would see some statements where we say the management and treatment of obesity have wider objectives than weight loss alone. And also, obesity management cannot focus only on weight reduction. More attention is to be paid to waist circumference and the improvement in body composition. And also, we mentioned about fat-free mass and fat mass. So coming to the current time, seeing that the diagnosis of obesity is still based solely on body mass index cutoff values, and body mass index does not reflect the role of adipose tissue distribution and function in the severity of the disease. As EASO, we decided to create a framework. And this framework was based on a Delphi process of 29 international experts. The steering committee performed a final revision and decided to approve a list of 28 statements. Consensus was defined as greater than or equal to 75% of expert agreement on a statement. Framework that we have created goes beyond BMI and aligns the diagnosis of obesity with clinical processes used for other chronic diseases. And the framework definitely treats obesity as an adiposity-based chronic disease. So what we have in hand? Well, the current obesity definition, the new obesity diagnosis, EASO obesity definition, is a BMI greater than or equal to 25, or BMI between 25 and 29.9, and having a waist to height ratio that is greater than or equal to 0.5 plus medical, functional, or psychological impairments or complications. So this is the EASO obesity definition, in addition to having a BMI greater than or equal to 30. Just a simple example of two patients. Patient number one is a 40-year-old male with a BMI of 34.8, and currently has no medical, functional, or psychological impairments. And patient 2 is a 35-year-old female with a BMI 27.3, a waist-to-height ratio of 0.6, and diagnosed with depression and hypertension. So on the right side, you would see a chart where you can tick, and for both patients, and decide whether they have obesity as a diagnosis. So the traditional definition and the new obesity definition by IASO say that these two patients have obesity. And the IASO definition of obesity, we think, is a practical and a pragmatic one. Easy to implement in clinical practice, including the use of treat-to-target thresholds. So we want it to be simple and practical and implementable so that the practitioners could easily understand. It moves away from BMI alone, recognizes obesity as a chronic immunometabolic disease, supports early intervention, less likely to exclude those with early disease, and supports a comprehensive clinical evaluation inclusive of obesity-related diseases. Well, I'm grateful as the president of the society to our team that you see here who have created this piece of work, which we consider, along with others, as a landmark work. And also, we, as mentioned before, have created a framework for pharmacotherapy of obesity, and that's also another landmark study that we have generated. And we will be presenting the second version of it, updated version of it, in Istanbul on the 13th of May this year. And I, as the president of IASO, am inviting you all to Istanbul. Thank you very much.
Okay.
Then we invite all panelists. So Barbara and Volkan, you sit on the other side. Catalin and Nicola will stay in the middle as referees.
Okay.
So you guys sit on the either side. You can pick and choose.
Please take a seat here.
No, I can stand up. He's like, there you go.
Please.
Yeah.
And in the meantime, if you have any questions to address to the speakers, it was a great session. The presidential address is not supposed to invite you to ask questions, but the others, in respect with the IFSO statements, OMS and surgery before and after, the great work for definitions in Lancet. Please.
Juan, please. Can you get the microphone working while they're doing
we have
it?
for Juan.
Yeah.
Okay, thank you very much. Well, I've learned a lot, so very interesting session. And obviously we'll define what we're going to do in the near future. I've heard about definition of obesity based on first BMI, then anthropometric measures and comorbidities, obesity-related diseases, etc. But what about direct measure of fat mass by DEXA and bioimpedance, which today is quite easy to measure?
So replies from both EASO and Lancet Commission sides. Whoever wants to start.
Well, as you said, those sophisticated methods are the best methods to show mainly, well, the amount, but mainly the distribution of fat mass and also information on fat-free mass. But what we are doing as EASO here, and our presentation, is simple and practical approaches for the practitioners to make the diagnosis of obesity based on anthropometric measures, plus the presence of obesity-related diseases.
Great, thank you. Then Lancet Commission.
Yeah, among our 56 experts, we had people from Africa, for example. That's different than the ASO Commission. And one of the claims were, we have a scale and a tape, so we need to do this universally. So although DEXA MRI may be a refinement for that, it correlates to the anthropometric parameters.
Well, at least give an option to.
It's an option.
Yeah.
In the Lancet Commission, it's there.
Yeah.
Making it more precise. Thank you, Juan. Then Francois?
François.
Oh, no. You want to continue?
No, I have 3 questions to Barbara, but I can
Yeah,
François.
okay, yeah. Let's wait for Francois' question.
Okay, thank you very much. It's about the definitions, and my question will go to the EISO since I'm one of the authors of the others. Just would like to comment first that a disease, to me, is also something which impairs or shortens life expectancy. This is important. In obesity, all our field, both surgery and doctors with drugs, are sitting on the SOS study, 2007, Swedish paper. Everything comes from here. There is no single other evidence of decreasing mortality. So going back to the definition, when we looked in our window of opportunity of a big cohort followed 25 years, we were able to see, I was just checking because I was asked, if you have clinical obesity when you are treated, and 1 year later you have lost clinical obesity or you still have what happens to mortality? I can tell you the difference in mortality is huge, extremely significant. What is the evidence with the ASO mortality obesity definition? Do we have any evidence that if you treat the disease that you define yourself, 1 year later you don't have the same definition, 27 and all this? Do we have any evidence, and do we think we are going to have any evidence that you are decreasing life expectancy?
Well, Francois was looking at me, but being the president, I don't have to answer all the questions.
No?
Barbara, you had the data.
Yeah, you can just throw Barbara under the bus. That's good.
I did show a slide of mortality, according to the definition, and the new EASO definition, which encaptures those with, does show an increase overall mortality. I don't know about your question where if you do the intervention, whether that changes. I'm not sure anybody.
Can I add a comment? Dror, with his Annals of Medicine paper, Annals of Internal Medicine, was perfect for the Lancet Commission. If you look at the data of Dror, in the definition of the ASO, BMI over 25 to 30 with one condition, maybe asthma, so treat them all, asthma, it may be related. He showed that there's no difference in mortality between normal weight and BMIs 25 to 30, which is the ASO definition. So a long story short, the definition of BMI of 25 plus one anthropometric parameter has the same mortality as the defined normal weight. So it doesn't add anything on mortality.
Can I add, to that? I think it's important when we do speak about diagnosis and disease definitions that we remind ourselves that there are concepts and pillars of medicine that are sensitivity and specificity. The broader the definition, the less specific the definition, the less the predictability, usefulness of that framework. Barbara just showed an interesting slide. If I understood, the ASO definition has no difference in mortality than the BMI definition only.
Thanks to
At that point, why don't we stick to BMI? Right? So the second thing is, as Ricardo said, the Dror study in Annals of Internal Medicine shows that when you define the clinical component of your framework, so broad as to say any, because that's the language they used, any clinical problem
maybe asthma,
associated with obesity,
migraine.
What you're doing, you're reducing the specificity, and it means that those conditions can happen even in people with normal weight. So no surprise, when you compare normal weight individuals in the Dror study and people with obesity and the same dysfunction, there is no difference in mortality. So back to your question, if you don't have difference in mortality at baseline, no intervention is going to change that.
I think first of all, it did show, whilst it didn't show as high mortality as the obesity classification, it did show an increased mortality. So I think we can't ignore that. So I think that needs to be captured in the definition. I think that we need to be careful with just sort of taking, because our definition, for example, includes any complication which is mental health as well. So it might be that perhaps if we just look at sort of metabolic ones, we could see that, do you know what I mean? Mental health might not cause that cardiovascular mortality.
You put it in definition.
When we're talking about other diseases, we were talking about, for example, asthma, brain disease, and the fact that it's not actually, I think that our fundamental difference here, and I just want to say, is just that we think that we don't have to wait for the complication for the disease to be there. That is about the only fundamental difference, I would say, that we have in terms of the
I would argue with that. There's not what the Lancet Commission said. There is no weight. The definition of a disease is a snapshot.
Well,
it doesn't have a direction of whether you wait or you don't wait. If you say Parkinson's disease is characterized by these symptoms, you're not asking people to have a Parkinson until you diagnose it. You just want to diagnose it, right?
If you have HbA1c of 6.5%, you've got type 2 diabetes. You don't have to wait for the complications of type 2 diabetes to present.
Who is asking for that? Who is asking for that?
Well, what we are saying is that, when we apply our definition, that disease is there already. We don't have to wait for the complications to appear before that. There is an inflammation going on already.
All people with obesity have inflammation.
Well, I think that's a very simplistic, there are inflammatory changes going on.
Can I just conclude on this way?
In some patients, not everybody.
I think we do because, in the next 7 minutes, we need to define how to work together, and we're not really getting there yet.
Let me work together towards that. And I think,
Go ahead, Francesco.
Let me work together, Barbara. So I think you very nicely said it. You don't have to wait for the complication. But a disease diagnosis doesn't call you to wait for the complication. It just takes a picture of that person and say, this person has a health status that is different than this person who doesn't have those problems. It doesn't say wait for those things to happen. So if the ASO framework wants to manage obesity, it would benefit from introducing a clinical definition like the one of the Lancet Commission that tells you which one is which one is risk, and then intervene with risk management, which could lead to pharmacotherapy used for risk management. Or when you have a disease, you can't treat them with the same intensity, with the same dose of drugs, with the same things. You want to know that.
This is a surgical audience.
So working together means you can, if you use a diagnosis that's a real diagnosis, then I think we can all work together.
Let's make a definition for surgeons. You have a colonic polyp and a colon cancer. Would you treat them the same way? Would you give them chemotherapy for a polyp? No. So it's the same continuum. See, if I have the same continuum of care, I'll gauge the intensity of treatment according to the diagnosis. So this is a simple example. So pre-diabetes, they don't take insulin, most of them. Type 2 diabetes, 30% of them probably would take insulin. So it's a difference of intensities of treatment. Based on a diagnosis.
I'm absolutely positive that the panelists have multiple questions to each other, but we will give the floor for a short, concise question.
Yep. I'm not a surgeon, I'm an endocrinologist as well. My question is, you started off, Paulina, saying that only about 3% of people get treatment. And these definitions seem to broaden how many people have obesity. We seem to be spending a lot of time broadening the definition rather than focusing on those people, as you just said, who the average person can look at and say, you need to jump in first. Why are we doing that?
Thank you for the question, because I was going to ask that, and I was like, I didn't even pay for that. So thank you very much. So,
you're absolutely right in the sense that even not just bariatric surgery, only about, up to possibly 3% of the total population living with obesity is actually getting access to pharmacotherapy.
It's 8% in a recent
8% maybe, obviously, hopefully it will, but it's the point is you're absolutely right that the majority of people are not being treated, and that's because obesity is still not seen as a chronic disease, let alone us trying to define the subtleties of what is a disease. But having said that, I don't think we need to underestimate the fact that we still need to define it as a disease, because there are treatments coming along and they are going to get cheaper and cheaper and cheaper. And unless we are, as a community, we really make an effort to unify, I guess, in what is the diagnosis of obesity beyond BMI, then lots of people will not receive treatment when it becomes more accessible, in the world.
But you hit the nail. With the Lancet Commission definition, you prioritize those who need most now. And the other ones, you stratify their risk and intervene individually with the higher risk, either medical or surgical or both. So you got the spirit of the Lancet Commission definition.
That's actually the major problem in my mind also.
I think we need to be careful with definition and who needs to be treated first. And I think going forward, in fact, there was a very nice Nature paper about using obesity scoring systems, which can then prioritize those with a high cardiovascular risk, which probably just goes beyond just the BMI or the waist to height ratio and looks at a number, I think 20 parameters or something like that. It's just been published, and I think it's very good. Obviously, we probably need the OBS score. We need maybe to validate it or try it.
After the definition, the diagnosis was made.
Okay, so and I can't remember what diagnosis that they used, but I think we need to move. I think together as a community, we need to. We're not fighting here. We're just discussing. Can I just say we're being very constructive? But
no, this is a constructive discussion.
Definitely not, and it's great to do that. But I think we need to be more sophisticated going forward about who needs to be prioritized for treatment properly. Because even clinical and preclinical, there's no real, scoring of who needs. In the clinical, there's no staging criteria there. It's just sort of.
We only have two. Yeah. We only have 2 more minutes. Volkan, go ahead.
Shortly, Barbara and I are here just to tell you our story. And we want it to be as simple as we can. Simple for the practitioner to understand. And our paper is 2 or 3 pages, and the Lancet Commission paper is how many pages? 42 pages. So I think we have to be simple for the practitioner, because as EASO, we are covering the education and training of all the healthcare professionals, from dietitians to physical activity people, psychologists, surgeons, primary care physicians, and all. So primary care physician needs simple papers so that it's easy to implement.
Thank you, Volkan.
So that's our point.
I think with the lack of time, because we want everybody to join the opening ceremony in the exhibition area, can everybody with 2 words say that, or maybe max 5 words, that what should we do to implement this and benefit most from both of the Lancet Commission and the EASO framework? Ricardo, you get to start. Max 5 words.
To synthesize?
To kind of like how we can actually move forward, because it doesn't really matter if we write these papers or do these studies, we need to implement it in real practice.
We have two different frameworks. Ours is a diagnostic framework. We do not intend to dictate a management framework. So it's a diagnosis, and after that, as Francesco pointed in his presentation, we go for obesity staging and how to manage surgery, medication, both together. So there are different ways that we need to merge and not to conflate the information among them.
So collaboration.
Collaboration
Was your word.
Thank you for the word.
Yeah. I know, jet lag. Okay,
yeah. I'm
Barbara?
just going to say collaboration, let's be pragmatic and practical.
Yeah.
Well, we are supposed to be the judges.
Yeah. No, you were the referees
So
keeping them apart.
We just think that we need an extra time in the welcome.
Exactly. Then we listen for Kathleen, you have a comment?
Yeah, I think we will learn to work together better. That's for sure.
Exactly. Francesco?
not sure if 5 words, but one is accuracy. Accuracy is part of diagnosis, part of medicine. We cannot deal with such a big problem like obesity, so heterogeneous, and have a simplistic definition. I don't think it's a matter of how many pages it is. By the way, there's 3 pages infographics. The Lancet Commission can be read in 3 minutes. But we cannot be simplistic. We have to be accurate, and that's medicine. The second thing is diagnosis comes before management. And I think if professional organizations want to collaborate, collaboration is another word, I think that would be the very stepping stone. Start with a diagnosis and then make the management framework coherent. Risk as risk, disease as disease. That's the Lancet Commission. Treat risk as risk, disease as disease. Obesity is both things. There's no point in blurring the picture.
Volkan?
Well, we as EASO recognize obesity as a disease. So if you don't do that, it's not possible to prevent obesity and also treat obesity as a disease. I believe we should collaborate, but how are we going to collaborate with the Commission as a society? I mean, we would collaborate with societies, I assume.
Definitely. I think IFSO is more than willing to do that, and we are actually working together for the global guidelines currently, so hopefully that's a step forward. Thank you very much for our distinguished panelists and everybody that stayed. Thank you very much.